So welcome everybody. We're not going to do the classic awkward waiting and telling that we're going to wait a couple of minutes to see people trickling in. We actually prepared a bit of a burning question for you, for the panel as well as the audience. So if you're in the audience, what we'd like to do for you is to open the chat and to also answer the question that's coming up. So my name's Thomas, I'm from Belgium. And basically the burning question that I have is, before we get started, is basically what's your favorite guilty Belgian pleasure? Is that first waffles? Is it chocolate? Is it beer? Or is it fries? And yeah, I know that some of you are thinking fries are not from Belgium, but actually they are from Belgium. Even though they're called French fries, they basically stole that one from us. So for the audience, please use the chat below. And if you prefer waffles, tell us what topping you would like to have on there. If it's a beer, what's your favorite? And if you're eating fries, make sure to tell us whether you eat them with mayonnaise like real Belgians do or not. In the meantime, I'm super curious to learn from our panel what you like to indulge in. So please,
Thomas,
if you could all state. Yes.
The chat is disabled for some reason.
Chat is disabled. Can you look that up? How I can enable the chats? I can't see that in the settings. There is some Q&A. Yeah, I don't see how I can enable the chat. So, but you can use the Q&A. I can see some people in the chat, so it should work. So let's just keep on going. If you want, you can put it in the Q&A. Otherwise, you can put it in the chat. It seems to be working. So if you could, for the panelists, tell us your name. And then would love to learn what your favorite guilty Belgian pleasure is. We'll go alphabetical order. So Ali first, then David, Dhruv, Mariza, and Wayne as last. So Ali, what is your favorite Belgian pleasure?
Yeah, Ali Khan with Oak Street Health, and I would have to say fries. Just, you know, a good base on which to build a lot of different things.
David?
David Lerman from Boulder Care. I'm going to go waffles. I had a round numbered birthday recently and received a waffle maker for my birthday, and I've been on a waffle kick ever since.
Nice. Dhruv?
Dhruv Vasistha firsthand. One of my favorite places growing up in New York City was Pomfret. Like, could always catch me on a late night at Pomfret grabbing some fries and mayo. So I'm definitely going with fries.
Cool. Mariza?
Hi, Mariza from Zócalo Health. I hope I'm not the only one here that has to pick beer. I remember several trips to Belgium and visiting all of the amazing beer halls and absolutely loving beer.
Great. And Wayne, you're last.
Wayne Lee, Headspace Health, 100% chocolate. So my kids are going to be sorely disappointed when Halloween comes around.
Nice. Okay. Thanks everyone for the wonderful insight into your cravings. I'm obviously very well aware that there's irony in here that we're hosting a webinar and panel on healthcare and that most of these foods would not be classified as particularly healthy. But on the other hand, whole generations of Belgians grew up on this stuff and we have a pretty good life expectancy. So the outcomes are good. Before we officially get started, a little bit of housekeeping. So first want to thank you, big thanks to the panelists. Everybody's really busy, has a lot to do, so making time for this is not obvious. So big thanks to that. Also big thank you to the people who registered. We have 500 registrations, more than 500 for this panel discussion, and that's really beyond expectations, but it's also clearly an indication that this dialogue should be had and that it really strikes a chord in the industry. So super Thankful for that. Also want to thank Health Tech Nerds as our knowledge partner. So healthtechnerds.com has been instrumental in helping us to set up the State of CareOps survey and to start the dialogue in the community there. And last thanks goes out to Rick, my colleague. He has been absolutely instrumental to getting all of this set up. He's also the one who is in the Q&A looking at your questions and so helping to organize everything. The session is recorded and will indeed be shared with you at the end. So you can share it with your colleagues or look at it later on. There will be Q&A at the end, so feel free during the webinar to already post your questions as they come up. Rick will monitor that and will push the questions while we get to the end. Talking about the chat or the Q&A, whatever is working for you now that you've used it, please continue doing so throughout the session. So if you hear quotes that are worth mentioning, or if you want to react to what's being said, please do so. Now, our goal with CareOps is to really fuel the dialogue in the community. So CareOps is not a business or for profit. It's really to share best practices with each other. That's also what this panel discussion is for. And so help spread the word by using hashtag CareOps. You can see it in the bottom left of the screen. If you're tweeting about this or on LinkedIn and you want to post something, please use that hashtag and fuel the dialogue. So let's get started. In a couple of minutes, I'll ask the panelists to formally introduce themselves to tell a bit more about the role that they have at their specific organizations. But before we do that, just a quick recap on what brought us here today. So CareOps revolves around the care flow. And the care flow exists in many different names at different organizations. You might see the terms on the screen, and one of those terms might resonate more at your organization than the term care flow, but in essence, they're all the same. It's a sequence of activities that is performed by a care team or a patient or both to achieve or maintain a desired health status. And if your organization is providing care, your care flows will determine the cost of care delivery. But also the work experience of your care team, the efficiency of your care team, and ultimately the outcomes of the patients. And those are some of the topics that we'll be talking about today. Now, the way that we design and implement and optimize care flows is broken. You might recognize some of these, not specifically these examples, but everybody has seen these kind of flow charts or guidelines being published in 60-page PDFs. And as a very concrete example, the WHO published its first COVID-19 clinical management guidance in March 2020. And a quick question to the panel: how long did it take the WHO to come with the very first iteration to that initial guidance? So initial publication was March 2020. When was iteration 1.1 published? Any idea? It was 1 year and 3 months later. So it was June 2021. That is for me, that was just mind-boggling that it took so long to update that guidance. Now, we don't have a lot of people from guideline committees or the WHO in this call. Our audience is mainly people at care providers. And so what does this actually mean for care providers? Well, the thing is that a well-designed and well-implemented care flow does lead to better outcomes, and it does lead to a lower cost to deliver those outcomes. And the better your organization is at designing and implementing, at monitoring and getting insights out of these care flows, the faster you can iterate and learn from them. And so faster iteration, faster learning means that it becomes a sustainable competitive advantage if you can run through this CareOps loop or CareOps life cycle faster than your peers. And so CareOps, basically, as you can read, this is the current definition of CareOps is all about the tools and the practices to bring key roles together to design, implement, monitor, and improve care flows. So To know how the landscape and how the industry is doing on this, we, together with Health Tech Nerds, we launched the State of CareOps Survey in July and August. This was the very first time that this survey was launched. We got a total of 147 respondents for all of the people in the audience who have responded to that survey. Again, big thanks. What was great to see is that we were able to capture a broad range of care providers, really from the very early startups, seeing just a handful of patients, to companies that have existed for more than 15 years and have upwards of 100,000 patients they see in a given month. So that's a pretty broad range. In total, we extracted 15 insights from the State of CareOps. That's also published online, so you can find that through the careops.org website. And so this panel is basically about discussing these results together with this amazing roster of panelists. So I'll stop sharing for a moment, because what I'd like to do next is to go into kind of a more formal introduction by each panelist. So what is your role at your organization, and how are you involved in any of these CareOps principles? After that, we will show relevant insights from the State of CareOps Survey 2022, and I'll launch a couple of questions to the panel, and then we'll get into the discussion. We'll go inverse alphabetical this time, just to make it interesting. So Wayne, do you want to kick us off, please?
Thanks for picking on me, Thomas. Wayne Lee, VP of Care Operations at Headspace Health. Great to be here today. Great to see the panelists as well. So I work directly with Karan Singh, our Chief Operations Officer over at Headspace Health. He's also the co-founder of Ginger. It's my charter, and I oversee 4 direct organizations: our clinical operations, our coaching operations, our product operations, and our support team. And our support team is a wonderful team that interfaces directly first with members that onboard to the Ginger app. And there's also a dotted line who are connected to the care talent team. So they're the team that hires our therapists, psychiatrists, and coaches. And so in my role, I'm intimately involved in the build out of systems and tools and processes to essentially enable our care providers to deliver excellent care.
Great, thanks, Wayne. Mariza?
Hi, everyone. My name is Mariza. I am the Chief Operations Officer at Zócalo Health. Zócalo Health is a very new company. We launched services to California in July and preparing to launch in Texas in a matter of days. We are designing an experience to focus on the Latino community and bringing them back into primary care. We have structured our care model with a community health worker as a front door to really engage the community, build relationships, and provide an experience through community into primary care, and then a follow-up afterwards through a direct-to-consumer membership model. My role at the company right now, because we're small and new, is everything. Everything from thinking about the customer journey to learning about primary care, how to access it, enrolling, and then building that relationship with our community health worker team, scheduling appointments and follow-up. So currently we are virtual only with plans to expand into the community, but very early days and a lot of learning around care operations in the few weeks we've been delivering care.
Okay, great. Up next is Dhruv.
Hey, everybody. I'm Dhruv Vasistha. I am VP Product at Firsthand. Firsthand is a tech-enabled, peer-led patient engagement and navigation business that takes on risk for individuals living with serious mental illness on managed Medicaid and uses a team of peers, individuals with some type of lived experience recovery journey, as well as social workers and nurse practitioners to find these folks, engage them in building trusted relationships around their health, enroll them into benefits they're eligible for, do some chronic care stabilization, and then navigate them to the existing outpatient primary care and behavioral health chassis, typically federally qualified health centers and community mental health centers. My function is working on product, And there's like a little bit of design there that we're going to be hiring soon, but essentially like product design, data, security, and IT. We think about care operations often because we are building a experimentation and problem-oriented culture, first and foremost. So essentially, we are constantly thinking about how can we take problems identified through manual processes and do very, very entrepreneurial, hacky ways of solving those with tech, with Microsoft Office, and a bunch of other ways to move quickly and learn. So really excited to share a lot of those insights from our experiences.
Exciting. Thanks, David.
Good morning, good afternoon. I'm David Lerman. I'm Chief Technology Officer at Boulder Care. We are an addiction treatment provider seeking to offer high quality evidence-based treatment for primarily opioid addiction and alcohol addiction to those who need it. We are entirely virtual, just trying to improve access, particularly for low-income and Medicaid populations, to everything from clinical care, so prescribing buprenorphine and other medications for addiction, to peer supports, care advocacy, help with social determinants of health, and sort of trying to bring together all the services someone would need to navigate their recovery process.
Great. And then last but not least, Ali.
Thanks, Ella. Good morning, good afternoon, depending on where you are. I'm Dr. Ali Khan. I'm a practicing general internist on Chicago's West Side and Chief Medical Officer of Value-Based Care Strategy at Oak Street Health. Oak Street Health is a national network of primary care centers exclusively focused on the needs of vulnerable, structurally marginalized seniors, Medicare enrollees, and Medicare Medicaid dual eligibles, of whom about just shy of half of our patients, of our 200,000 patients around the country across 21 states, fall into dual eligibility. We spend a lot of time in non-fee-for-service models thinking about what is the work required to shift primary care from a reactive sort of fee-for-service dominant approach to true proactivity that integrates clinical excellence, care management, and just good old-fashioned caring about folks into the right kind of work where we can apply time and resources and follow-through to really build trust. And so we started about 10 years ago here in Chicago, Illinois, now spread to 150 centers across 21 states. And in general, I think a really strong example of how care operations, and in the portfolio that I lead, where I spend a lot of time thinking about how our population health work, our care management work, our broader efforts at clinical excellence really come together in terms of saying, how do we deliver the kind of care that we'd want for our parents and grandparents? Ultimately, that's the true mark of whether we are having meaningful success. And then how does that work as we contribute to the larger ecosystem, as Mariza and others are thinking about, in terms of delivering real community investment and engagement that moves us forward, as opposed to just keeping people in structurally marginalized situations as they may have been for decades. So excited to be here. Have spent a lot of time in this space, and including in a couple other places along the way. And I see some old friends from those places, Hayora, CareMore, and others, thinking really about how do product, clinical operations, population health, and clinical expertise come together really around the principles of care flow to build an iterative, constantly evolving and constantly improving organization, and how do we build a discipline therein. So excited to dig into the details there.
Great. So yeah, I'm really humbled by the experience and also again the breadth of what you all are doing in your organizations in the panel. So my name's Thomas. I'm co-founder at Awell. Awell is on a mission to make care flows work harder than care teams, and our software is used by care teams to design care flows and embed them into their tech stacks. And I'm also the co-author of the CareOps articles. So let's get started with a first insight. Resuming the share, so you should be seeing one of the insights that come from the state of CareOps. So just giving some background, the results basically showed 66 unique team combinations across 81 responses in the survey. And what that made me think of is the following. So going back to Belgium, there's not a lot of sports that Belgium excels in. If you look at any Olympic game medalist, you'll see that immediately. But there's one sport that we are pretty good at, and that's soccer. Now imagine the Belgian team going to the World Cup end of the year, but without a goalkeeper or without a striker on the field, right? And so what this insight told me was, as a care provider, you're actually battling in the care provision World Cup, right? Every day. And the question is, can you afford not having the key roles play in your team to do that? So the first insight is really around, what roles are involved in designing and validating and then improving these care flows. And I'd like to give that first question to Ali, please. And to the other panelists, please speak in on whatever Ali's saying, or give us your own experience after that.
I'm sorry, I was so distracted by baby Dhruv that I did not hear the question. Can you please repeat it?
He's in that moment where he just needs to be held, and that's the only way that he's not.
Distracted in the best of ways. Let me be clear.
Yeah.
I'm so happy that we can have this on the panel recorded and everything. So Ali, the question is basically, the composition of the team designing, implementing, and improving these flows is crucial. That's basically the thesis here, right? But who should be in that team? Who is in that team at Oak Street Health, for example, and how are you thinking about that?
Yeah, and I would say this is a place where I think we've evolved our thinking over time as we've become more aligned around an agile infrastructure, right? I think it's very easy at organizations to sort of start with a product mentality of wanting to lean in from the context of cross-functionality, but then very quickly defining cross-functionality as either, engineering plus operations and business leads, or engineering and clinical, right? And without necessarily realizing, like, hey, the full suite of stakeholders is actually super important when we're thinking about what are last mile challenges. Ultimately, the true, realization of the potential of CareOps, right, requires that we have a really rigorous focus on how we ensure the last mile of people either using a feature, people identifying a bug, or people actually delivering what we intend to ship to that end user, right, to that patient, particularly in structurally marginalized communities that may or may not have the same level of broadband access, right, or technological rigor, or technological availability, or access that many of our team members may have, right? Getting that full suite of context, and at times even pulling in that patient experience, can be crucial towards making sure we are designing for the full suite of needs, right? I think the reality in our space is that we are dealing with all sorts of needs at once, right? And so a simple feature that may appear simple to myself from a clinical perspective may actually be quite complex when you think about this from how it requires interactivity from a health plan perspective. I'll take an example, right? Like being able to do something like, I would like to, know when I'm prescribing what asthma inhaler, right? What albuterol inhaler is on formulary for the patient that I'm taking care of, so I can prescribe that quickly, right? Seems like a simple process, enormously complex, right? Like tons of different data issues, business questions from the context of contracting and where we are from a data flow perspective, real questions from a pharmacy perspective and how that relates to some of the work that we try to do in Part C and Part D stars, and obviously real patient implications from both a cost and affordability lens, but also from like what happens when we get that wrong, right? So unless we have that full suite of folks engaged meaningfully with more than just sort of like voyeurism, but really committed to the architecture of product development and that ongoing investment that ongoing iteration really requires, then we inevitably leave something behind. So I'd say from a lot of trial and error in the true spirit of Agile, we have learned the hard way that that's what's required along the way.
Any thoughts, reactions? David?
I agree with all of that, and we're obviously a smaller company, and so have fewer stakeholders. But I think one thing that I would highlight is the tension between sort of speed of iteration loop and number of stakeholders. Particularly as we've been growing, where we're much smaller, but we're maybe 150 people now. As you start to try and bring in a clinical owner plus legal plus product plus potentially software engineering plus maybe a peer plus the patient, your ability to make small changes quickly goes down. And so those things are often in tension of how inclusive you want to be, how much feedback you want to get, and how quickly you want to move. For us, one thing that we found very helpful is kind of the product role. We call it service design, but sort of that person who wears a product manager hat, who is responsible for deciding what stakeholders to include and knowing enough to know who cares. Right. So rather than say that legal and clinical oversight have to be in every decision, having someone who's really empowered to say, I have relationships with all of those people, and I know that we're just changing this one question. Only these two people care. We're going to do it. Maybe we'll send a notification that says, hey, we're doing this. If you happen to care, let us know. But who can cut those corners to avoid having a 10-person meeting for every small change.
Wayne, I see you nod a lot.
Yes, it's 100% to both what David and Ali said. It's really a practice of prioritization, right? So getting the right stakeholders at the table at the right time. So especially when we're scoping, we're doing a discovery process in terms of what problem that we're solving for, and especially like when you're running it's a care organization that's providing care, right? The end user ends up either being the clinician or ultimately we're serving care to the members. And so it's important upstream as well, including the product team, data science, our clinician team, engineering, operations, et cetera, just to get in line that we're all solving for the same problem. Because David, to your point, right? Because when a company's at a smaller state, I mean, it's easy to move fast and course correct, right? As we get bigger, there's a lot of opinions, and there's also secondary effects in terms of what we build may have secondary impacts on other teams. And so for a couple of our projects right now, like we're also including the support team, right? Because if we're implementing something operationally for the clinicians, it also impacts how the support team is interfacing with our members. So really, it just goes back to its takeaway is like, we just all need to be aligned that we're solving the exact same problem.
Maybe picking up on that last thing that you're saying, right? Aligning people. When do too many stakeholders become too many? So too many cooks spoil the broth, right? What team size is it unworkable? And related to that, who is in charge here? Is it clinical? Who is in charge?
It really depends on the initiative or the function that we're building. Typically, like if we're building something out for the clinician team, so let's say an internal electronic health record that we're building out, we definitely want the clinical team's feedback at the early stages. But eventually, like once it moves into operation and build, it's probably it's either a function of the product lead if it's more product focused, they're project managing the entire process, or it could be operational if it's a broader cross-functional group that's driving it. But ultimately, the accountable person will probably be on the clinical team.
Dhruv?
Yeah, I think like there are two elements to this, like piggybacking on what Ali and Wayne said. I think the first is, as you can probably see from your insight, there's not going to be any standardization of like the stakeholders involved in CareOps anytime soon. And so from that perspective, the way that we thought about it at firsthand, especially given that we have such a diversity of like individuals in the community teams, whether that's peers, social workers, nurse practitioners, some of those folks deliver clinical care. Some of those folks have very unstandardized workflows and are doing more like non-medical care coordination. The important thing for us, I remember asking our CEO this. I was employee number 2 at the business, and I was like, why are you hiring a head of product as employee number 2? That makes no sense. And very quickly, I realized that really, and this is something that I'd wanted myself, the idea was to really infuse product culture and product thinking into the business from the beginning. And so we literally have, like a section in our onboarding where we explain what product management is and how and product thinking, the product development lifecycle around, start with problems, then define metrics like leading and lagging indicators, then define hypotheses, then define solutions. We do that with every new employee at the company. And so I think for me, it's less of who is the person on the team and more of, is there some good problem solving skills on the team such that you're not starting with solutions and you're starting with problems? And I give clinicians the same example, because like from patient paying, where I say, hey, what do you need to do good post-discharge care coordination? Like, person's coming out of the inpatient setting, how do you do good care coordination? And I tell them, most clinicians will say, I need the medical record. I need to know what happened in the hospital. And you're like, okay, cool. So if it was just you, you'd like request the medical record and read through 100 pages and try to like figure out post-discharge follow-up. But if you had a product person or a product thinking, you'd say, well, what's the problem we're trying to solve? Well, like, we don't know what happened to the patient when they were in the hospital. Well, why do you care? Well, the hospital is going to mess up their meds. Okay, like, well, what else is the hospital going to like mess up? Oh, like, the hospital is going to request DME and we're going to have no idea. And the hospital is going to say that they need a specialist and PCP follow-up and we won't know. And so I say, oh, so you need discharge orders in discharge summaries. And you need specifically 4 things in those discharge summaries in those 70 pages that are going to be actionable to what you do to do good care coordination. And when I give that example, people are like, okay, I get it. Like, if we started from the solution and just been like, hey, tech, or hey, ops, or hey, somebody, I need this, we wouldn't have actually solved the problem. It's the, cross-functional collaboration and the problem definition that really empowers you to truly make the impact that you want to make. That's one. I think from the perspective of accountability, we say this, and I think it's sometimes uncomfortable for ops folks at tech-enabled services businesses, but we say that tech is jointly accountable for any of the outcomes that you're driving. The timelines may just differ. So, ops teams and clinical teams can really do great work on the order of days, where they're like, hey, we need to change a workflow. So let's go change it let's change the service design. Let's go change it today, tomorrow, next week. Tech is more step function change, or, product is more step function change. And we always ask 2 questions. We're like, how can we, what is a problem? What is something that's a problem today, or is that not that acute, or what is something that's not that big of a problem today, but it breaks down in 3 months and 6 months? And it's that latter that tech usually gets involved, and product and eng usually get involved and have shared accountabilities with our ops teams. Or similarly, it's, what are you doing manually today that is really inefficient and gets in the way of, taking care of patients? It's like, oh, you call the hospital to find out somebody got discharged. You can just get an ADT feed to do that. So those are just like some of the examples where we try to create a different type of close collaborative relationship. Doesn't even really matter who it is and what their title is. It's really more just what is, for a cross-functional team, the problem-solving approach and framework that they have. As long as they have a good product orientation there, then they're set up for success.
Okay, great. Thanks. Fabulous insights already. We'll move on to the next insight. So yes, so what we see in the results is that 80% of all survey respondents reported using care flows at their organization. But of those who responded that they use, only 36% report having more than 6 care flows live. And what that made us think of is like a restaurant saying, hey, we're going to serve, I don't know, Thai food, but they've only written recipes for 6 dishes, and the chefs are basically left to their own to cook the 20 other dishes that are on the menu, right? And even if you have chefs that can cook well, what that means is it's not going to provide a consistent experience, or you cannot ensure a quality standard for your customers, right? So the question I have here, and we'll start with Mariza this time, as a very young company, right? You have a million things to do, and some of this might seem a bit longer in the future to tackle, right? How are you thinking about addressing also this at the very beginning?
Yeah, great question. We had to really define a goal and how we wanted to go to market and what our focus is going to be. Because when you think about Latino health and some of the disparities that exist within the community, you can really become overwhelmed by all of the things that you need to do. We need to get more mental health. We need to get more primary care. We need to get more and more and more. And that can become overwhelming. So it was incredibly important for us to be very focused on what do we want to achieve achieve when we launch, and how do we start to build flows to achieve that? And it's not simple, but we really wanted to focus on how do we get a member connected to a primary care provider within the same day that they want to see that provider. So that meant a lot of things around building trust with the member, about getting them into our system, about enrolling them. All of that had to be a good experience, or we lost trust, the relationship fell apart, and we never got our member to a primary care provider. So we really had to drill down on what are those flows that will allow somebody to get into our system, and what are those flows that encourage people to maybe drop or even not build trust with the experience. So I think, in the early days, we really just had to focus on that first mile of how do we enroll people? How do we make that a good experience? And then how do we put a person there that could help navigate any questions, any issues? We don't have a big product team. We don't have a big tech team. We have a big human team. A lot of community health workers were hired in the early days, and they're playing the role of a lot of these care flows and workflows, doing a lot of it manually and making the duct tape work in the background. But what that has allowed us to do is start to see what works, what doesn't work, and where can we build flows, versus if we had started with workflows, if we had started with we have to build this experience, then I think we would have lost a lot of patients and we would have lost a lot of trust in the very beginning. So it was really important for us to be very narrow in what we were trying to achieve, hire humans to do a lot of that manual work, and then iterate and start to build with some of those feedback loops.
Okay, yeah, that's so basically in the beginning, there's a lot of value in keeping things manual to be able to iterate and be flexible. You don't want to put everything in concrete yet, right? But as you scale,
Right.
then my question is, right, how do you make sure, and I think Ali, you made a comment to that earlier in the introduction, how do you make sure that what was designed by this, this team that we just discussed earlier, how do you make sure that the design equals or approaches what is actually being delivered in terms of care? How can you ensure that, especially when you're scaling up to the numbers that some of the companies here have already seen?
Yeah, and I'll say, I think this comes back to something that I think Mariza was circling around, which is like the quality versus quantity sort of debate is actually very real here, right? And we can get into a big discussion over like how would you cut this data if by like age of an organization or vintage of an organization. But I think even for those of us that are relatively more mature in the space, having a bunch of care flows versus having a bunch of care flows that actually work are two different things, right? And so again, like we can design all sorts of things and continue to iterate on it. And if we are not realizing that like we've built a fantastic system for building patient-centered, care plans, right, that are required to be approved by patients, but then that like the goals from that engine don't shift into the place where our teams actually like have daily work lists, well, nothing is going to happen, right? And it leads to sort of check the box mentalities as opposed to going deeper to say like, what are we doing to actually activate this human, right? What are we doing to support them and lead them in a way and like side by side to actually get the end result that we want from health, health improvement and activation. And so there are many, many, many examples I can cite from like, the last 10 years, both at Oak Street and elsewhere, where like very good intentions and a tightly run process with lots of good iteration still end up at the, just shy of the finish line because we don't get to the place of true, not even just beta testing to the question in the audience, but like, post-surveillance marketing, right? Or post-surveillance investigation to actually really feed back. And so I would not necessarily I'm not necessarily like saying here and being like, oh, only six or a few more care flows, that's a problem, right? I want to know the depth of the care flow. I want to know what's happening to it. And on some level, if Wayne and team only have 5 care flows, but they're superb at them, that's probably adding more material good than having 35 of them across a huge set of behavioral health conditions, but that all kind of stays superficial. In health, that's the difference, right? It's like whether it's D2C or B2B, like there is still an issue of depth, and how we get there becomes more critical in our work than I think in other necessarily parallel industries.
Yeah, that's fascinating. Anybody wants to react to that?
Quick thought, Thomas. I love this discussion. What we've been trying to focus on is how we can do more with less, right? And this is not about taxing the system, but trying to build out the most efficient process possible. And so how we look at things are there standardized processes, right? The processes that keep the lights on. Then there's additional processes that help contribute to care flows, but that we can also iterate on. And so anytime we try to make a change to one of the processes, we always ask, what are the efficiency gains we're going to get from this? What's the ROI? Is this going to improve clinician sustainability? Is this going to improve member care? XYZ. But totally agree. I mean, it's having a bunch of processes. And one thing we are dealing with is just a lot of manual processes and a lot of custom processes. And that tends to clog up the system and just creates headaches across the board.
And the only like contrarian point that I'll add, because this was very humbling for me, is sometimes you don't need care flows, you just need really talented people. And like I was thinking about this because we try to take a very non-traditional approach to primary care visits, where we almost hire nurse practitioners that are really good at motivational interviewing. And I remember shadowing one of our nurse practitioners for a whole person assessment. And, for our whole person assessments and our structured assessments, we have like this intelligence around, what questions you ask and what subsequent, questionnaires or screeners that triggers. And I just remember this nurse practitioner talking to this woman and being like, you just had bariatric surgery. And they were just like, oh my God, like show me pictures, like before and after. You look so good. They were just kind of gushing over how amazing this woman looks. And that was the conversation that led to, how are you feeling about post-surgery diet? How are you feeling about, your nutrition? How are you feeling about, your kids' health and seeing you as a role model? And that's when she talked about her hypertension. And there was no history of hypertension in past medical records we'd solicited for her. There was no history of hypertension in the claims data that we had. And I think about that often because I'm like, what workflow, what predetermined in a laboratory workflow would have led to that conversation and that discovery? And, instead, should we have just let this nurse practitioner be an amazing nurse practitioner and kind of gotten out of her way and met her where she is? So, that's the other way to just kind of think about it of what are we really here for? It's to empower clinicians and to empower our care teams. And that empowerment may not always look like standardization or in the frameworks that we define them.
Yeah, that's not a contrarian point at all. I think it's right on the nose, Dhruv. That's really great. I'm just looking at the time; it's flying so fast. So we're gonna move on to the next insight. I would love to talk for an hour on each of these, but we have some more ground to cover. So the next insight is that the majority of care teams is flying blind to some extent, and a third of the respondents even report that the only thing they look at is performance metrics. So to give that a bit of context, so performance metrics of a care flow could be sign-up rates, drop-off, engagement, completion rates, things like that. Now, again, looking at this from another perspective. So let's say you're boarding an airplane, right? And knowing that there's a 1 in 3 chance that the crew in the cockpit is only going to monitor altitude and speed, but not the oxygen level in the cabin, right? Would you feel comfortable taking any airplane at that time if you have 33% chance of running into a crew like that? So the questions I'd like to ask around here, and maybe David from your side. What's the risk of optimizing the wrong thing if you're not balancing your metrics or not measuring a balanced set of metrics?
I would say it's a sure thing that you'll end up optimizing the wrong thing if you're not watching. Just maybe tying it back to the previous conversation, if you have 2 questions: are people following the process? A, and B, is it solving the problem that it was designed to solve? And often they're related. So if you have good clinicians or good caregivers, when the business process is not solving the right problem, they'll find a way to solve the problem. So right, a good provider, if they're getting forced into a business process or into a clinical process that's not serving the needs of the patient, they'll just go around it and do something else. And so I think those are equally important. I think about we added in a PHQ-9 assessment recently, which is a standardized assessment for depression, and it's a reasonably standard thing. And after we sort of rolled out that care flow, I shadowed watching someone deliver it for the first time, and it was traumatic to watch. It was horrible. It's a bunch of questions about depression and asked without follow-up and without clear action. I think they're net negative for a patient. Asking someone, how many days have you wanted to quit work? Have you considered suicide? And then moving on to the next thing without a follow-up to the fact that a human being in front of you just said, yes, they've contemplated suicide in the past, is traumatizing. And so I think that question of like, well, why did we introduce the PHQ-9? Who is it important to? Whose needs is it serving? And what are we doing with the results is really important.
Quick answer from the panel on this one, because then we're going to go into the last insight and then into Q&A. Or just a lot of notes on what David just said. Yeah.
I'll just add that as an early stage company, I think, one of our tenets going into our launch was measure everything. Measure everything. We'll talk about it, we'll debrief, but I think what was incredibly important to recognize and implement was making sure everyone on the team was aligned on why we were measuring everything and what we were going to do with the data once we received it. Because as an operations person, I want to know all the details. I want to know what happened, why it happened, when it happened, who it happened to. Before some of the care team members, they didn't see value in maybe collecting that data or didn't collect that data or didn't capture it. And so making sure everyone is aligned on why are we collecting this information? What are we going to do with it? And what kind of insights? And also just recognizing, okay, we collected a lot of data. It wasn't useful, but that's okay. Like we're flexing our muscle in collecting data. We're flexing our muscle and making sure we're asking questions, and we're flexing our muscle and discussing it. And if it doesn't result in anything, that's okay. But we have to have that mentality and that tenet of measuring everything and just trying to look around corners. So I think that was, something we had to build and continue to build kind of a cadence around in the company.
And Mariza, I think that's super critical, right? Because I think when you're trying to build financial, operational, and sociocultural arguments, right? Like that span of data is really critical. Obviously, you have to guard against measurement fatigue, right? But I think the biggest way to guard against that is how you're constantly making that relevant to teams, right? At some level, we have to have regular conversations about what are we doing with this, right? Because otherwise, if you're asking teams to act against every single thing you're measuring, that can get overwhelming. If you just keep measuring and you don't tell them why, they will quickly lose interest, right? And no amount of incentive design is going to fix that, right? So it really comes down to at the end of the day, what feeds optimal, care team and care process iteration in this way is that human capital work of how are we showing what we're doing? How are we talking about what we're doing? How are we discussing whether or not what those measures are showing us is relevant or not? And if so, what should we do about it? How do you make that a democratic process in a way that's still led through a very efficient manner, as opposed to just, not saying anything about it?
And to Thomas, real quick, just to David's first point about the at the end of every process is a human being, right? And so I think in operations, it's very easy to fall in the trap of only focusing on business metrics or financial metrics, operational metrics like cancellations, et cetera. But I think the other side of the coin is the care metrics. It's the clinician sustainability, like the member satisfaction scores, the clinician satisfaction scores. So like David, to your point, it's like this person is administering a PHQ-9, but it was a horrible experience for them and for the member. And what was the point of doing this, right? So.
Great stuff. So going into the last insight here. So we've covered the care team, or sorry, we've covered the CareOps team composition, we've covered designing them, we've covered a bit of the implementation, a bit of the monitoring. The last stage is basically closing the feedback loop and improving your care flows, right? And so something that struck us when analyzing the results is that basically only 19% of respondents are using new medical research to improve their care flows. And so last analogy of the evening, it's a bit of an unfortunate one given all the hardship that people are going through, but this made me think of the war going on in Ukraine. And let's say that you're President Zelensky and you're dealing with that war that is in your country. And during a meeting with your generals, one of them says, hey, I have this new technology, it's readily available, and tomorrow we can get crucial intelligence on the troop advancements on the Russians, right? And we can get that on a daily basis. But then the president deciding, no, I don't need that intel in my plans to win this war, right? So new medical research seems like such an important aspect of iterating on your care flows. Otherwise, we're actually doing a disservice to our patients because they're really not benefiting from the latest advances. So just wanted to put this to the panel, basically up for anybody who wants to react to that. Maybe, yeah. Why do you think? Maybe that's the right question to ask here. Why do you think that that is so difficult? Because there must be something behind the numbers here. Why is it so difficult to fold that medical research into your care flows continuously?
Well, Thomas, I think you highlighted at the beginning of the presentation the amount of time it takes from research to advisory board to guidelines, and that length of time being sometimes years. And I think we're all in good company in the audience that we are trying to innovate in the moment, and we're trying to gather data, learn from the data, and then adjust the experience. And sometimes in the medical community, research takes a long time. And I think there's a balance between taking that research and building it into your workflows and your clinical model, but also being able to take an iterative approach to your care delivery and to the way you deliver your operations. So I think we're definitely in our company trying to balance that, knowing that the research is tailing by years, if not extremely lacking within our community.
I also think that, like when you talk about incorporating medical research into care operations, where I think a lot of innovation happens is not like the medical research you choose or kind of like using like finding some new medical research and then saying, hey, like let's adopt this. I think where the innovation happens is the application of that clinical research for your particular care, care model, or for your particular patient population. So for example, surprise, surprise, we are going to be implementing a transitions of care program. That should be unsurprising to nobody for anyone working with a Medicaid population, anybody working with a population that has acute needs. Like transitions of care are just when you can really make an impact in somebody's life because they are open to changing. They're like, what's been happening, they're coming out from a hospital and they're saying, hey, like I'm in a moment of crisis. I'm acknowledging that I'm in a moment of crisis because I went to a hospital and was hospitalized. Maybe I should try something different. Like that's an inflection point. Now, patient paying enabled transitions of care for like hundreds, if not thousands of customers. But the way that transitions of care program was rolled out was quite different. The way that Firsthand will roll out its transitions of care program is going to be unique to what does transitions of care look like, led by a peer who's doing that outreach from a notification that somebody was discharged from the hospital, as they try to introduce that person to a social worker and to a nurse practitioner fairly quickly to say, hey, is there some other way that we can help? So transitions of care, very well documented in the research. Like we know it works. We know how it can work. We know how it can be leveraged at a high level. The implementation, the execution is, I think, where the innovation is. So I almost am like, the framing is adjacent in how I think this manifests in a lot of companies.
I see a lot of nods from the panel. Unfortunately, I see that we're almost at the end of the hour. Again, I think everybody would love to keep this conversation going. We also have several questions from the audience. I see. I would propose that we take one a question from the audience right now, and then Rick and I will see how we can answer also, maybe with the panel, the other questions, but more asynchronously. So maybe an interesting one is looking at the questions here. Yeah, about machine learning. So what aspect of the roles that you're all fulfilling goes to thinking about exploratory data capture or efforts into machine learning? And we're not talking about replacing humans here, but augmenting what they are doing. Who would like to comment on that for the last couple of minutes?
I think at Oak Street, we spend a lot of time in sort of that exploratory data capture, precisely the point that Mariza raised earlier, right? Of that, like, because we're capturing a bunch of data, we don't know what we don't know, right? But then we trust our data science team to sort of help us think through what insights we're revealing, that then how that tells us things, right? I would say that's a good example of, to Dhruv's point, it is the contextualization of the medical literature or specific problems that are being validated with a p-value of 0.05 in peer-reviewed research that we then say we bring to our context, right? And we say, like, well, if the p-value is 0.07, right? Like, is that really? It is still, like, is that really a huge problem, right? What does it mean to take, say, for example, the collaborative care model in behavioral health that has only been validated in, by and large, in mood disorders and like depression and anxiety? And how do you think about applying that across a broad chassis when the vast majority of patients that we take care of have severe mental illness or SMI or substance use disorders, right? And like, what is the application of that? How do you think about taking research done in a fee-for-service context and applying it when you don't have some of those constraints, right? This is the work over and over again that happens. And so in the same way that we have to think about how we apply and learn, and given the unique context that we have, I think from the exploratory data capture is very similar, right? Where we rely on our data science team to help us make sense of things, oftentimes by asking questions for which we don't have obvious answers through our typical care pathways or care flows, but where they are deriving some of that insight. So I think when if you start with a very small or constrained set of structured or unstructured data, then you're not going to get to that place of sort of understanding how far you can get. I think the bigger the aperture, earlier to Mariza's point, the better off you are for when your organization is really ready for taking it heavily from a machine learning standpoint. Not every organization is at that stage, right? But once they are, I think it becomes really crucial.
Okay, so with that comment, I just like to take 30 seconds to touch upon a couple of the takeaways I've written down, and then we're going to close the panel discussion for the evening. So the problem-solving mindset is more important than the role. That's an important one. Thanks, Dhruv, for that one. Doing things manually in the beginning to keep things flexible, Mariza. The depth and quality of processes is more important than the quantity. Care flows are not a substitute for non-talented people. I think there's really a lot of quotable stuff in here, or things to frame on the wall for people who want to do that. And then measure whether people are following the process and whether the process is solving the problem that it was designed to solve by David. So again, thank you very, very much for this discussion. Not all the questions have been answered. By far, not all of the things have been said. We hope that this really is the beginning of a very fruitful dialogue. We are thinking of organizing a couple of happy hours in the coming weeks, months. New York, San Francisco, Los Angeles, Las Vegas, probably London as well. And so if you scan this QR code, obviously the recording will be shared, so you'll get access to this link, or click on the link if you're interested, because these are not planned yet. We just want to see if people are interested, and then we'll get it organized to talk more. And all of the questions that came in the Q&A, we will make sure that they get some kind of answer in the coming days. Big thanks to panelists for doing this. Time flew by for me. I hope it was for you too. And hope to see you soon.
Thanks, everyone.
Bye.